In this program, we are going to look at the psychiatric disorder called depression and the medications used to treat it. After viewing this program, you should be able to understand the basic signs, symptoms, and physiology of depression, verbalize therapeutic treatment goals for clients with depression, discuss the categories of psychotropic medications used to treat depression, and describe assessment, side effects, and precautions to use while caring for clients receiving these drugs. Depression is one of the most common psychiatric diagnoses. It is also a significant public health problem. A person who suffers from depression can experience major changes in the ability to function on a day-to-day basis, or may suffer a prolonged loss of ability to function.
Michael, talk to me. You're not eating, you're not sleeping. You've been sitting here for hours. What's going on with you?
I have every reason to be happy, but I'm just not happy.
Depressed individuals may have psychomotor agitation or retardation, feelings of worthlessness, difficulty in thinking and concentrating, and diminished interest or pleasure in activities. They may also experience disturbances in sleep, mood, eating patterns, body weight, sexual desire, grooming habits, energy levels, and socialization. In severe cases, the individual may have recurrent thoughts of death, dying, or suicide, and even develop psychosis. The first step in dealing with a patient who suffers from depression is to assess the degree and nature of his problem with careful exploration of any suicidal ideas or plans. This assessment may be conducted by a psychiatrist, psychologist, or other healthcare professional.
On a scale of 1 to 10, 1 being the best you've ever felt in your life and 10 being the worst you've ever felt in your life, where would you put yourself right now?
I'd be about 11.
While there are numerous ways to evaluate depression, using an assessment tool that scales the patient's degree of depression establishes a quantitative baseline. Though in itself the rating may have limited meaning, over time the healthcare professional can use the scale to detect changes in the patient's condition. The etiology of major depressive disorder is very complex, and despite the great progress that has been made in recent years, it is still not very well understood. Patients with major depression have symptoms that reflect changes in brain chemistry, affecting norepinephrine, serotonin, and dopamine transmitters. Based on our relatively limited understanding of these neurotransmitters, there are various hypotheses that attempt to describe the pathophysiology of depression and the role of medications in relieving depression. Put simply, most antidepressants are designed to increase the level of a specific neurotransmitter at the neuronal synapse. This is accomplished by one or more of the following therapeutic actions: boosting the neurotransmitter synthesis, blocking its degradation, preventing its reuptake from the synapse into the presynaptic neuron, or mimicking its binding to postsynaptic receptors. The relief of depression with medication probably requires multiple direct and indirect therapeutic actions involving one or more neurotransmitters. The degree of relief does vary, and research continues to find medications that will bring relief to patients with refractory depression. The currently available antidepressant medications are equally effective at treating depression. Therefore, selection of any agent is primarily based on the side effect profile and the patient's antidepressant medication history. Generally, there are a few basic principles that apply to the treatment of depression.
Michael, I'm so glad that you decided to come in today. Thank you very much for coming, and you too, Alice. I hope we can give you some help.
The practitioner should begin by establishing the patient's level of functioning prior to the onset of depression, because the goal of treatment is to return to that level. Because there is a lag of 2 to 4 weeks to clinical efficacy for antidepressant medications, but the onset of side effects occurs rapidly, it may be difficult to achieve good patient compliance. This is just one of the reasons that optimal treatment involves a combination of medication and psychotherapy. It is most common to see patients who are receiving just one medication for their depression. Usually the prescribing provider will discontinue one drug to try another, although some patients do have good benefit from a combined approach. After one depressive episode, risk of recurrence is 50%. This risk increases with subsequent episodes, 80% after 2 and 90% after 3. For this reason, drug therapy is normally continued 1 to 3 years after the patient has returned to normal function.
Come on in, Michael.
Hi,
Nice to see you.
Nice seeing you also. Hey, Michael.
Hi, Michael.
Hello.
So, Michael, you know we're here for your team meeting.
Yes.
You've been to a team meeting before, and we're very curious to find out how things are going for you, how you're
The
feeling.
team must determine the best time to take the medication to suit the patient's daytime schedule so the agents do not interfere with work, school, or social activities. Antidepressants that have sedative side effects are usually administered at bedtime, while those that have stimulation side effects are commonly administered in the morning. Medications used to treat depression fall into 4 broad categories: tricyclic agents, monoamine oxidase inhibitors, selective serotonin reuptake inhibitors, and multiple mechanism antidepressants. The first group we will look at are the tricyclic antidepressant agents, commonly referred to as TCAs. These were the first medications developed in this group and for this reason are referred to as first-generation agents. For many years, they were the primary pharmacological agents in the treatment of depression.
Thank you for letting me come into your home to check on your...
The TCAs are effective in treating all depressive subtypes, especially the severe melancholic subtype of major depressive disorder. The TCAs generally have the same side effect profiles as the other antidepressants, although the intensity of those side effects varies. Examples of tricyclic antidepressants are doxepin, Sinequan, amitriptyline, Elavil, and imipramine, Tofranil. One important characteristic of this class of antidepressants is the length of time it may take to achieve a noticeable therapeutic benefit, while the side effects can show up after the first dose. Therefore, all of the tricyclics have to be taken for an extended period of time before they achieve a notable therapeutic benefit. In addition to its antidepressive action, TCAs also affect other receptor systems, with the result that neurologic and cardiovascular adverse effects are often reported during TCA therapy. Elderly patients taking TCA should be monitored closely, with particular attention paid to those with genitourinary tract problems, including men with prostate conditions. Another common and potentially serious side effect of the TCAs is orthostatic hypotension. Blood pressure measurements for these patients should always include readings with the patient standing as well as sitting. TCAs may cause cardiac conduction delays and may even induce heart block in patients with pre-existing conduction disease. People with abnormal heart rates must be monitored to ensure that these products do not aggravate any existing conditions. Sudden cardiac death has been reported from TCAs used in children. The side effects most frequently reported with the use of TCAs are anticholinergic related. For example, dry mouth, constipation, blurred vision, urinary retention, dizziness, tachycardia, and memory impairment. Other side effects include sedation, sexual dysfunction, and an increased appetite leading to weight gain. Any of these side effects may become more troublesome in the elderly patient and require closer monitoring and reduced dosages. The therapeutic range is very narrow for the TCAs. The dose which achieves the desired results for the patient and the toxic dose, that level which can cause injury or death, are very close together. An overdose of as little as 1 gram, the equivalent of 10 100 milligram tablets, can result in potentially fatal cardiac arrhythmias. Patients with impaired ability to clear medications from the system need to be closely monitored to avoid a potentially lethal buildup. It also means that patients at risk for suicide should only be prescribed TCAs when other classes of antidepressants are not effective. Care providers must be alert to suicide ideations in patients who are prescribed and therefore have ready access to TCAs. Another group of antidepressants is the monoamine oxidase inhibitors. Examples of MAOIs include phenelzine, Nardil, and tranylcypromine, Parnate. This is a small group of first-generation antidepressants that are not used as frequently as the TCAs or SSRIs because they have many precautions and side effects. The MAOIs have been shown to be most effective for treating a specific type of depression, that is, atypical depression. Clinical features of atypical depression include mood reactivity, irritability, increase in sleep and hunger, and psychomotor agitation.
How are you feeling?
I'm still feeling just as bad as I did when I got here.
These drugs remain useful for those patients whose condition proves refractory to the other agents, and sometimes for patients who can use the added stimulation they provide to counteract the psychomotor retardation seen with their depression.
Sometimes jittery.
MAOIs block an enzyme system in the body that is responsible for breaking down monoamines such as norepinephrine and serotonin. As with the other antidepressants, this leaves more of the neurotransmitters available. There are several dietary precautions because of drug-food interactions. Patients need to avoid aged meats and cheeses, chocolate, caffeine-containing beverages, beer, and red wine. Potential for a hypertensive crisis has also been observed when MAOIs are administered concurrently with certain other medications, such as decongestants, appetite suppressants, stimulants, dextromethorphan, carbamazepine, and non-MAOI antidepressants. Also, meperidine is contraindicated in patients taking MAOI antidepressants. Patient education regarding drug-food and drug-drug interactions is critical when recommending treatment with these agents. Side effects are common and include dry mouth, blurred vision, constipation, urinary retention, hypotension, weight gain, memory impairment, and sexual dysfunction. One result of these side effects may be poor patient compliance. Careful education, close monitoring, and slow dose titration are advised to help with compliance issues. The risk of suicide can be significant, especially if the patient is severely depressed. Careful monitoring of the patient is necessary until the medication has had a positive effect, and the patient is able to effectively cope with the stresses of daily life. Another broad group of agents used in treating depression, and the most common choice, is the selective serotonin reuptake inhibitors, or SSRIs. To date, a number of SSRIs have been approved for the treatment of depression. These include fluoxetine, Prozac, sertraline, Zoloft, paroxetine, Paxil, escitalopram, Lexapro, and citalopram, Celexa. As their name implies, the selective serotonin reuptake inhibitors work by blocking the reabsorption of the neurotransmitter serotonin. This leaves more of the chemical available to maintain a normal chemical balance in the brain. Unlike the TCAs, the SSRIs inhibit reuptake of serotonin into the neurons to a much greater extent than they inhibit the reuptake of norepinephrine, so they have less impact on other systems in the body and a lower side effect profile. Because the SSRIs have a much lower incidence and severity of anticholinergic and cardiovascular side effects than the TCAs, orthostatic hypotension is not a significant side effect. Patients are generally not prone to sedation and have less blurred vision and mouth dryness. If the patient takes an overdose, it is less apt to be lethal. The most common adverse effects associated with the SSRIs include varying degrees of central nervous system excitation, gastrointestinal effects, and sexual dysfunction. SSRIs may have a cardiovascular effect resulting in bradycardia, a slow heart rate. Paradoxically, in some patients, SSRIs may elevate blood pressure and increase the heart rate. Patients with existing cardiovascular problems should be monitored closely. Some class-specific side effects associated with the SSRIs include nausea, diarrhea, headache, tremor, overstimulation, and insomnia. Mental agitation and restlessness may be experienced, and confusion may arise, especially after a rapid dose escalation. Decreased libido and/or difficulty achieving orgasm may also be an issue for the person on SSRIs. The presence of such side effects may call for increased monitoring, a lowering of the dose, or even discontinuation of the medication. The SSRIs can inhibit enzymes that metabolize other medications and therefore elevate the blood levels of those agents to toxic levels. Some medication classes that could be affected by this inhibition include the antiarrhythmics, anticoagulants, antipsychotics, neuroleptics, and the TCAs. When these classes of medications are administered concurrently with the SSRIs, lower doses may be necessary, and the patient should be monitored closely. Serotonin syndrome is a very dangerous and potentially fatal condition caused by excessive serotonergic activity. It generally occurs within 24 hours of initiating the medication, after a dose increase, or as the result of an overdose, and can be the result of combining an SSRI with another antidepressant drug. Symptoms include rapid onset of altered mental status with confusion and agitation, as well as nausea, sweating, hyperthermia, and palpitations. The condition usually resolves within 24 hours after the offending medication is withdrawn and often requires aggressive supportive therapy until the crisis has abated. Discontinuation syndrome is most often associated with short-acting SSRIs such as Paxil and Zoloft, though it may also be seen with other groups of antidepressants. It results from abrupt discontinuation of medication therapy and tends to result in somatic, neurological, and psychological symptoms. Although generally not dangerous, it is uncomfortable and distressing for the patient. A slow tapering off of the medication tends to avoid this syndrome. Most SSRIs are metabolized by the liver and excreted primarily through the kidneys. Therefore, doses or dosing frequency should be decreased in patients with hepatic or renal impairment. Routine lab tests may be prescribed to monitor liver enzymes, blood components, electrolyte balance, and kidney function. There are other agents with actions and side effect profiles similar to SSRIs, though they are not technically in the same pharmacological class. They are considered multiple mechanism antidepressants and tend to enhance both serotonin and norepinephrine. The current literature suggests that these antidepressants often have a more robust efficacy and a greater likelihood of achieving symptom remission than single mechanism antidepressants. These multiple mechanism antidepressants are bupropion, Wellbutrin, venlafaxine, Effexor, mirtazapine, Remeron, and duloxetine, Cymbalta. They also have side effect considerations. They tend to have slight stimulating properties and can worsen sleep patterns in some people. Through assessment of the patient, the optimum time to administer the medication can be determined. Bupropion has a low incidence of sexual side effects, anticholinergic, sedative, and hypotensive effects. A disadvantage of bupropion is that it does have an increased seizure rate, and it should not be used in patients with history of a seizure disorder. Venlafaxine has a very low potential to cause anticholinergic and hypotensive effects. The most commonly reported side effects, which appear to be dose-related, include nausea, constipation, sedation, nervousness, and abnormal ejaculation or orgasm. Mirtazapine is associated with a lower incidence of sexual dysfunction and nausea compared to the SSRIs. Mirtazapine may cause sedation and weight gain, which may actually be of some benefit to depressed individuals with insomnia and decreased appetite.
I used to be tired when I wake up and still wanting to go back to sleep.
Right.
Now I'm waking up, I'm ready to conquer the day, get out there and do what I have to do. I have the energy to do my evening runs like I used to, my jogs, and everything's much brighter now, much brighter.